Today, we start our deep dive with news that really just hit headlines. A candid public announcement that throws a sudden, harsh spotlight onto one of the most notoriously aggressive diseases known to medicine.
Yeah.
We are talking about the revelation by former U.S. Senator Ben Sasse, who is only 53, that he has been diagnosed with stage 4 metastasized pancreatic cancer.
Just a brutal diagnosis.
Okay, so let's unpack this. We've synthesized the coverage of his announcement, which includes his very frank personal reflections alongside, detailed medical and oncological sources to give you a full picture.
Right.
Our mission here is twofold. First, we need to understand the political and, the deeply personal context of his announcement, why he chose to share this specific message of hope.
And then the science.
And second, we will conduct a serious and thorough deep dive into the medical realities of advanced pancreatic cancer, its complex biology, its brutal prognosis, and why critical, proactive, supportive care is just mandatory for anyone facing this.
What's fascinating here is precisely how a public, personal story can become a powerful teaching moment about a really complex and highly lethal disease.
Exactly.
We will synthesize why pancreatic cancer, specifically the most common form, pancreatic ductal adenocarcinoma, is so difficult to detect early and what the current modern medical strategies are designed to achieve. It's absolutely crucial for you, the listener, to grasp that at this advanced stage, the focus necessarily shifts from cure to a sophisticated combination of aggressive life-extending treatment and managing quality of life. We're aiming for a factual and comprehensive understanding of the full picture.
So Sasse delivered the news in a very public and unapologetically blunt way on Tuesday, December 23rd via an X post. He confirmed he was diagnosed just the week prior with metastasized stage 4 pancreatic cancer, calling it nasty stuff. It's a death sentence.
He didn't pull any punches.
No, but then he immediately broadened the philosophical view, saying, we all already had a death sentence before last week's. We all do.
Which is a powerful way to frame it. For listeners who might need a little context on Sasse's background, he represented Nebraska in the U.S. Senate from 2015 to 2023.
Right.
His political profile was really defined by his vocal criticism of political tribalism and, significantly, his opposition to President Trump, culminating in his vote to convict the former president after the January 6th attack.
And he also showed a clear prioritization of family over his career pretty recently. He resigned midterm in 2023 to become the president of the University of Florida.
A huge post.
A huge post, which he then voluntarily left the following year when his wife, Melissa, was diagnosed with epilepsy. So there's a consistent timeline of him stepping away from these traditional power structures to focus on what matters most to him personally.
Ray, you see a pattern there.
And his Christian faith was clearly central to this latest announcement, especially noting the timing during the season of Advent. He was very precise in distinguishing true hope from simple optimism, calling true hope stiffer stuff. This hope, he explained, was rooted in a real deliverer and in looking toward an eternal city without cancer. The response from figures across the political spectrum was immediate, reflecting the gravity of the news. Vice President J.D. Vance sent prayers, and House Speaker Mike Johnson publicly cited Romans 8.38-39.
And despite the sober acceptance of the diagnosis, the personal statement wasn't passive. Sasse specifically said he isn't going down without a fight and that he will pursue available treatments.
Right.
And this is the critical narrative bridge that connects his personal story to our medical deep dive. He mentioned finding hope in the jaw-dropping advances science has made the past few years in immunotherapy and more.
That's a powerful statement of belief in scientific progress. So let's ask the tough question. Is that hope justified?
That's the right question.
Here's where we look at the cold, hard medical reality of this disease, because pancreatic cancer is just tragically lethal. It ranks 12th globally in incidence, but it jumps all the way to the 6th spot in cumulative mortality. That disparity tells you everything you need to know about its lethality.
And that lethality is unfortunately growing. I mean, the sources predict it is set to become the second leading cause of cancer-related deaths in the USA by 2030. That is an extremely sobering projection.
Wow.
This isn't just about incidence. It's driven by two primary factors, the aggressive tumor biology itself and the nonspecific, silent nature of its symptoms.
You mentioned silent progression. So what's the immediate consequence of this quiet advance?
It leads directly to late diagnosis. We see in the data that more than half of patients, around 57% present, already having metastatic disease.
Which is stage 4.
Which is stage 4. And stage 4 is the definitive crucial designation here, meaning the cancer has already spread from the pancreas to distant organs, most commonly the liver or the lungs.
So when we talk about stage 4, we have to talk about the prognosis reality that Sasse referred to.
We do. When the cancer has spread this far, it generally cannot be cured. That brutal benchmark that modern oncology is fighting tooth and nail to break is the median survival rate for stage 4 pancreatic cancer, which is often estimated starkly between 2 and 6 months.
2 to 6 months.
Or typically less than a year. The goal of all subsequent treatment, therefore, is not eradication, but life extension and improving the quality of the life that remains.
That median survival rate is incredibly grim. But you've also noted that the overall picture is not static. Is there any good news we can offer our listener?
Yes, there is an important nuance. While the individual stage 4 prognosis remains short, the overall 5-year survival rate for pancreatic cancer across all stages has actually improved significantly over the last 30 years.
Okay.
It has gone from 4% to 13%. That increase is entirely due to improved surgical techniques and better oncological therapies. So while the disease remains devastating, we are making incremental, important progress in fighting it.
Okay, let's look deeper at what drives this cancer at the cellular level. What makes it so aggressive and so resistant?
Well, the aggression is characterized by multiple molecular changes, but the vast majority of cases have one overwhelming genetic driver. The major genetic event, found in about 88 to 90% of patients, is the somatic KRAS oncogene mutation.
Okay, let's quickly break that jargon down. When we say somatic mutation, what does that mean for you, the listener?
It means the mutation was acquired during life, typically due to environmental factors or just random chance, not inherited.
Got it.
And the KRAS mutation is the master switch that goes haywire. It doesn't just start the cancer, it actively drives proliferation, enhances the tumor's survival, contributes heavily to metastasis, and is a major factor in making the tumor resistant to chemotherapy. It's the Achilles heel of pancreatic cancer research.
And you mentioned there's an inherited element too, separate from that acquired KRAS mutation.
Correct. Beyond the somatic changes, we find germline, meaning inherited from your parents' mutations, in about 9% of individuals. This emphasizes why every single patient must undergo comprehensive genetic testing. It's personalized medicine 101.
Given the general screening for pancreatic cancer is not recommended for the average asymptomatic adult due to its low overall incidence, understanding risk factors is crucial. Why should the average listener care about these modifiable risks?
Because modifying them is your only proactive step. The leading modifiable risk factors highlighted in the literature include cigarette smoking, which carries a relative risk, or RR of 1.8.
So, to put that in simple terms, if you smoke, you are 1.8 times more likely to develop this cancer than a non-smoker.
Exactly. Heavy alcohol intake also increases the risk. That's an RR of 1.6, as does a high BMI. That's an RR of 1.1 for every 5-unit increase. Changing these lifestyle factors can genuinely mitigate your risk.
And let's address that complicated link between diabetes and the pancreas.
It is perhaps the most fascinating and alarming link. Diabetes is a known risk factor with an RR of 1.5, but the relationship is bidirectional. New onset diabetes.
What does that mean bidirectional?
It means that new onset diabetes, especially if it appears suddenly after the age of 50 and isn't accompanied by typical obesity, can actually be an early symptom or prodrome of the cancer itself.
Yeah.
The growing tumor is interfering with insulin production.
Wow. So a new diabetes diagnosis could be the first warning sign.
It could be the very first silent signal. It means new onset diabetes in the right demographic should always prompt a deeper investigation by a physician.
This brings us to the segment of the population where screening is recommended, those with inherited risks. Who are these high-risk groups?
We're talking about people with familial pancreatic cancer, which is defined as having 2 or more affected first-degree relatives, or those with specific inherited genetic syndromes.
Like what?
These syndromes include BRCA12, Lynch syndrome, and Peutz-Jeghers syndrome. These inherited risk factors increase the probability dramatically enough to warrant intervention.
So for the 1 in 10 people who know they have a significant family history, what kind of surveillance are we talking about?
For these high-risk groups, surveillance is highly recommended, often involving annual imaging. These aren't simple blood tests, they are specialized procedures like endoscopic ultrasonography or EUS and high-resolution MRI. This surveillance typically starts around age 50, or critically 10 years earlier than the youngest affected blood relative was diagnosed. It's a proactive strategy tailored specifically for known genetic vulnerability.
Moving to the actual care pathway for metastatic stage 4 disease. As we discussed, the aim shifts from cure to life extension and symptom control. What is the current standard of care?
For metastatic disease, palliative chemotherapy is the unwavering standard of care. But thanks to those advances Sasse mentioned, this chemotherapy has moved significantly beyond single-agent drugs. We now use powerful multi-agent regimens.
Okay, explain the concept of multi-agent chemotherapies simply for our listener.
Think of it as hitting the cancer from several different chemical angles at once, rather than relying on a single weapon that the aggressive KRAS mutation can easily learn to resist.
Right.
The preferred modern combinations are either the modified FOLFIRINOX or gemcitabine combined with nab-paclitaxel.
And what kind of benefit do these aggressive regimens actually provide? I mean, the median survival time still sounds so minimal. Why hasn't chemotherapy improved more dramatically in this specific lethal cancer?
That is the central tragedy of pancreatic cancer. We have seen improvements, but they are incremental, not curative. FOLFIRINOX, for instance, showed a median overall survival of 11 months, compared to the grim 7 months previously seen with older gemcitabine alone.
So it's a 4-month improvement.
It's a 4-month improvement in median survival, which is incredibly significant for a patient and family, but it underscores the biological difficulty of this cancer. We also have newer options like NALIRIFOX, which continues to push those survival markers incrementally forward.
It's important to acknowledge the trade-off. These powerful drugs come with a serious cost, correct?
Absolutely. The aggressive nature of these regimens means high toxicity. Sources cite serious adverse event rates ranging from 60% up to 87%.
That's a huge range.
It is. However, the critical takeaway here, which sounds counterintuitive, is that despite the harsh side effects, chemotherapy is still associated with improved quality of life.
How so?
Because reducing the size and aggressive nature of the tumor alleviates the excruciating pain and symptoms caused by the disease itself.
That connects back beautifully to Sasse's hope in jaw-dropping advances. How else is science customizing the fight?
Well, the future is personalized. Every patient needs thorough genetic and molecular profiling. While the KRAS mutation dominates, you have to check for those small opportunities. For the tiny subset of tumors, we're talking less than 1%, that show DNA mismatch deficiency, immunotherapy using checkpoint inhibitors can yield remarkably promising survival results.
A real breakthrough for that tiny group.
It is. And of course, the huge, desperate, ongoing push is for KRAS-directed therapies that can finally target that 90% of cancers, fulfilling the promise of truly personalized treatment.
That discussion of managing toxicity and maximizing comfort leads us directly into the most crucial component of care for advanced cancer: supportive care. And we need to be very clear here. This is not synonymous with end-of-life hospice.
Precisely. Supportive care, or palliative care, is a holistic philosophy that must be integrated from the very moment of diagnosis and provided throughout the entire journey.
So from day one.
From day one. Its goal is comprehensive, relieving symptoms and side effects and focusing on whole-person care. This addresses physical, emotional, social, spiritual, and the often overlooked financial needs of the patient and their family.
Let's break down the physical symptoms that supportive care is designed to actively manage, because they are often debilitating.
Pain management is primary. Abdominal or back pain is incredibly common because the tumor presses on sensitive nerves. While pharmacological management involves prescription drugs, opioids, or sometimes nerve-specific medications like antidepressants or anti-seizure meds for localized difficult pain, doctors can use procedures like the celiac plexus block.
Okay, what exactly is a celiac plexus block?
It's essentially a nerve ablation. It's designed to turn off the pain signal coming from the abdomen. A doctor injects a substance to damage those nerves, preventing the severe pain signals from traveling to the brain. It's a targeted intervention to maximize comfort when oral medications just aren't enough.
And what about the practical issues related to digestion and bodily function?
Jaundice is another highly common physical issue occurring when the growing tumor blocks the bile duct. Supportive care manages this typically by inserting a small tube called a stent.
Right.
Plastic stents are used for temporary relief, while metal stents are preferred for longer-term relief to keep that duct open. Palliative teams also manage chemotherapy side effects like peripheral neuropathy, the tingling, burning, or numbness in the hands and feet caused by aggressive drugs like oxaliplatin.
But we can't stop at the physical. You mentioned the profound emotional toll. How serious is the mental health component of this diagnosis?
It is profound and often underestimated. The emotional concerns are highly prevalent. The sources indicate depression rates are astonishingly high in pancreatic cancer patients, up to 70% before diagnosis and a staggering 80% after diagnosis.
80%, that is a massive number.
It is. It speaks to the sheer psychological difficulty of receiving this news and undergoing treatment.
It sounds like psychological intervention should be treated as a required part of the treatment protocol.
It absolutely must be. Depression, anxiety, and distress are treatable conditions, whether through counseling, support groups, or prescription medications. Furthermore, supportive care handles the critical practical needs that distract from treatment, helping patients and families manage advanced directives, create wills, and navigate complex financial and legal issues, providing vital assistance with planning for the future.
So to pull this all together,
We've connected a difficult public announcement to the deep medical reality it highlights. Pancreatic cancer is characterized by its aggressive nature and tendency toward late diagnosis. But the modern multidisciplinary treatment model, which combines aggressive, multi-agent chemotherapy with proactive, holistic supportive care, offers the best pathway for improved survival and quality of life. The necessity and urgency for novel targeted therapies, especially those directed at the dominant KRAS mutation, remains profound.
that's a powerful summary. And the sources repeatedly emphasize one core practical necessity. Good outcomes rely entirely on the quality of communication between the patient and the healthcare team.
Absolutely.
Doctors can only effectively treat the symptoms and side effects, both physical and emotional, if they are aware of them, which means the patient and caregivers must be diligent in tracking and sharing every single change they observe.
You have to speak up.
You have to speak up. So what does this all mean for you, the listener? Consider how a disease predicted to become the second leading cause of cancer-related death by 2030, which often presents silently, underscores the immense importance of increasing early detection and surveillance strategies. Even though general screening is currently not recommended for the public, that tension between urgent public health need and current medical feasibility is a complex dilemma worth exploring further.